Hello everyone, we hope you've had a good week. Thank you for joining us tonight. This evening's webinar is on clarifying the PPE guidance. Joining us on the panel is Fadi Barak, who is an academic lead with a Master's in Dental Implantology with UCLan. He is duly qualified in medicine and dentistry and has vast experience in oral and maxillofacial surgery in hospital and primary care, and heads up the VSS Academy. Will Murphy, who has special interest in implant and cosmetic dentistry, having been placing dental implants since 1999. Will plays an active role in postgraduate education and is currently tutoring and lecturing on the implant diploma in London, and he's held a position of clinical assistant in oral surgery at the QE Hospital. Carl Horton, who has an MSc in both implantology, perio, is an implant coordinator, course leader and mentor for VSS, and is an honorary lecturer at UCLan. Faye Griffiths, who is an experienced hygienist, a tutor for the National Examining Board for Dental Nursing and presiding examiner. And we have Shelley Coley, who is a competent qualified head dental nurse with further qualifications in dental radiography and impression taking. With a keen interest in infection control, she has also completed an infection prevention and control lead course, gaining a distinction. We hope you find this evening interesting and helpful. Please feel free to send through any questions. We will do our best to answer them. As you can see, we are in good hands. And on that note, I'd like to pass you over to Carl Horton.
Thanks, Kate, and hello, welcome to this evening's webinar. I want to thank the panel for joining me this evening, and I want to thank you all for also joining. I hope you get something out of this. I do probably apologise beforehand because probably like a lot of you, I get emotional about some of the things that have been sort of going on and happening. What I'm going to do is hopefully just try and clarify some of the questions that I've been asked. And one of the reasons that we came up with this webinar is that a lot of people were asking lots of questions, and like yourselves, I felt a little bit lost. I have a nature for probably irritating my wife and asking lots of questions. I like doing lots of research. I like looking up papers, and I'm doing some work with Fadi on a research group, which I'm thoroughly enjoying. But I like to find out all sorts of things. I like to have evidence-based decisions. And in lockdown, it's gave me a great opportunity to do lots and lots of reading. I've become a very experienced consultant in helping my wife pick the right paint for the kitchen and the front room. But I actually think she was just asking my view because she just felt better by just saying, you know, what do you think about that? Unfortunately, the answer was often, but we have probably like most of you, a very tidy garden and a fully decorated house. And I'm being heckled by my son, who's playing video games on his mobile phone. So he's not being throttled. He just gets a little bit excited. So I do apologize for that. Anyway, without much more delay, what I'm going to do is I'm just going to start this little presentation, which hopefully you'll find useful. So what we're going to talk about is masks, respirators, and aerosols to start with. And then we've had some questions come in, so we're going to discuss those a little bit. So what's the difference between masks and respirators? And this was the thing that sort of intrigued me a little bit. I was curious as to why we were being informed that respirators were the way to go, and I wanted to know what the difference was between a mask. Well, obviously I knew the difference between a mask and a respirator, but I wanted to understand what the evidence was behind it. So I looked into it within detail. I knew that really masks were there to protect the wearer when we were doing the work. So, sorry, protect the patients from the wearer when we're doing the work. So if we decide that we're going to have a sneezing fit, that it's not going to be in the patient's face. So I understood that. I didn't understand too much about respirators, apart from when I'd done a bit of DIY, sanding stairs and things like that, but it gave me some protection against dust. So the primary difference is that the masks will protect the patients from the wearer, and respirators have a two-way protection unless they're valved. So some of the respirators that we can buy have this valve, and the problem with the valve is when you breathe out, you're breathing your air towards the patient. And one of the key things, I've put two little eyes there, is what they don't do is they don't protect your eyes, and that could be important. So I've got this little table which I've modified from little bits, and we've got single-use masks, which it's not so much sought after these days, but there's a little toilet roll there to show what use they actually are. And we have this thing called BFE, which is bacterial filtration, and we've got this sort of value at 3 microns, and I'll explain that a little bit more, but we can see the percentage there. And in the UK, for what we call particle filtration, there are no requirements for these masks. So these are your basic masks. What we're sort of gearing towards in the surgery as dentists is the second type of mask, or the surgical mask. And you'll see there's a reference number there for the European standards, and you should see that on the box of your masks. And we've got sort of really 3 types with the type R. So the first 2 types are not sort of that effective, but they're okay. I mean, we're looking at sort of what we call 95, 98%. And then we go to a type 2R, which you're hearing quite a lot about the surgical masks. And the type 2R mask, it's sort of filters at 3 microns at a 98% efficiency. And then the particle filtration there is at 98% at 0.1 microns. And why I've put that one in with a little asterisk is that for the UK, there actually isn't any regulation for particle filtrations on these masks, but in the USA there is. So I've included it because in the USA you've got level 1, level 2, and level 3 masks. So if you are buying masks and you see level 1, level 2, level 3, you can relate it back to type 1, type 2, and type 2R. And then we come down to the respirators, and then there's a different European regulation for that one, the 149.2001. And then you've got the USA ones and the Chinese ones. And what I've done as well is I've just helped a little bit by I've color-coded them, and I've color-coded them into sort of what stage we're at according to the government's Nando's effect. So as you can see there, we've got the FFP ones, which no one's really talking about. We don't really relate to those much. And then there's lots of talk about the FFP2s and the FFP3s. There's also talk about the N95s, and there's been some interesting debate about the KN95s today, and I'll go into that in a few moments. But the FP2s and the FP3s are the 2 types of respirators that are sort of being talked about, with the FP3s being sort of like very much your gold standard, having a filtration effect there at 99% or greater than, and your FP2s being at 94%. So you can see there's a slight difference in the filtration between those 2. And then the N95s, which are the USA version, and the KN95s, which are the Chinese version, slightly different in the way that they are comprised. But we're looking at about an equivalent to greater than a 95% filtration. Now, the question that was sort of being bandied around was that, are the KN95s acceptable? And the answer simply is yes, they are acceptable, but you've just got to be a little bit careful about where you're sourcing them from.
Carl?
So there are just slightly more counterfeit, apparently, KN95s around. But we'll go through this presentation and you can ask yourself a question whether that really matters or not, but I'll leave
Carl?
that. Yeah.
Sorry. They can't see the chart. I have explained that we are recording it and we will make it available for them to view. They can see all the speakers, but not the chart.
Okay. Can they see me as a speaker?
I believe so. Only faces, yeah.
Right. You can't see what I'm actually showing as a presentation then?
No, only partly.
Okay. If you make the window bigger.
Faces on the screen. All the panel's faces are on the screen, so it's covering the slide.
Right, yeah. So what I'm going to do is I'm just going to stop sharing for a moment. So I'll carry on chatting for a little while. And what we can do is we can. It's a real shame because I must admit this presentation is fantastic. It is the business. What I might do, guys, is what I'm going to do is I'm going to get you to leave, and then I'll bring you guys back in, and hopefully then, and I'll leave Kate. I'll leave you as the moderator in, and then I'll just get you guys to come back in again. I'll re-invite you if that's okay, and then we'll see whether that just makes it a little better. So there we go. How's that looking? Can you get any feedback on that?
Yeah, it'll come through in just a moment.
Okay. It's water, by the way.
Yeah, that's better. Yeah, it's all on. Yeah.
Okay. Now I've got quality control downstairs as well. So excuse me one moment. Any better? Excellent. So this is the table that I was talking about. Again, I'll share this presentation, show you, be able to see that. I'm glad you can all see it because that took me all of 10 minutes. And then we've got a little bit here about the way that the masks are actually made. And there's this thing called mount blown. So what they do is they get a polymer and they heat the polymer up, and then they sort of blow it through over these rollers. And we get this sort of fabric, this polymer fabric, and this is the way that these surgical masks are able to filter the particles. I'm going to come back again towards the respirators and the difference in the respirators that we're getting. So we're getting the N95s, and we're getting the FP2s, or the P2s, and they're pretty much equivalent to each other, with the N95s probably being slightly better than the FP2s. And I think that people are getting very worried about the difference in these, and they're getting all a little bit hung up, and I'm getting asked lots of questions. Well, which one is it? N95, FFP2? And when I read the HSE guidance and the public health guidance, they've kind of pretty much said, yeah, just go for the N95 or the FFP2, whatever's available. And it's almost like a hang up that we don't really need to worry about. It's a respirator. As long as you're getting the respirator at the FFP2, FFP3 level, or the N95 or the KN95, then you're fine. I mean, you can supersede that if you really want to spend the money on the N99s or there are other types of respirators that I don't go into on this presentation. So why is sort of 0.3 microns sort of banded about as a bit of a figure that we're looking at for our particle sort of filtration? And it's because when we talk about it, it's the most penetrating particle size we've got. So when they do the research, what they have a look at is they look at the particles that are hitting these filters, and they're seeing sort of how far these sort of particles can penetrate these filters. And anything that's sort of above or larger than 0.3 microns sort of sticks on the outside. It doesn't get very far. It doesn't sort of manage to penetrate the mask very well. Anything that's below that, so that's smaller than 0.3 microns, well, it behaves a little differently. What it does is it's sort of affected by sort of a random sort of Brownian motion, if you like. So as the particle doesn't really move straight through the air, it has this random movement. And actually what the masks are really good at doing is they're good at filtering these sort of smaller particles. So what they talk about is this 0.3 micron as being the most penetrating particle size. So it's the particle size that can sort of pass through the mask at the most distance, so penetrate it the most. And when we look at the sort of the coronavirus, certainly SARS-CoV-2, it's a pretty decent sized virus. So we're looking at sort of 60 to 140 nanometers. And when we compare that to MERS, you can see that they all the COVID viruses, they all sort of have a similar sort of size. They're all pretty big. And that sort of little image just sort of shows it there. So respirators, what are we looking for in a respirator? Are we looking for something that's got sort of fluid resistance? There are some that aren't fluid resistant, but because we're dealing with patients, if we're going to bother to invest in a respirator, then we're going to want some fluid resistance, because we do sort of talk about aerosols, and I'll talk about that in a little bit. You've got to decide whether you're going to go for valved or non-valved. The benefit of having it valved is it's probably going to be a little easier and a little bit more comfortable breathing wise. So as you're exhaling that air that you're exhaling, it's not encompassed in that mask. You don't have to push it out so much. So it's just probably going to feel a bit more comfortable. And the advice for those that's being sort of bandied around is that you put a mask, a surgical mask over the top of the valve, sort of going back to not wearing the surgical mask. It's going to filter that air and stop that air being blown directly into the patient. Do they or do they not need fit testing? They need fit testing. If you're going to invest in these masks, they will leak if you haven't got a fit test, and there's different leakages depending on the size of the mask. And that really hasn't been researched in a great deal. But the whole point of investing in the respirator is that you're trying to get the optimum protection that you can from being infected and filtering out these particles. So if you don't get it fit tested, well, then you lose some of the efficacy of the mask. So it kind of doesn't make sense that you'd invest in a mask and then not get it fit tested and then understand whether it's going to fit or not. And one of the problems with them is comfort. So they're not as comfortable as wearing a surgical mask over time. A lot of people are getting complaints, they're not feeling comfortable with these. And what you can do is you can sort of reflect on that and try the masks. So there are certain masks that fit people and there are certain masks that don't fit people, but they're certainly different to wearing a surgical mask. So we're going to look a little bit about the evidence. I'm going to talk about that a little bit now. And it is a little bit interesting. I was kind of quite curious as to whether or not they actually did offer us sort of any more protection than actual surgical masks. So do respirators actually work better for us than a surgical mask? And the reason that I thought about this is really early on, I just couldn't understand, if we were at risk that much, why we weren't seeing more of healthcare workers that are doing dentistry getting ill. And I just couldn't figure it out. And I thought, well, maybe it's because we haven't seen as many patients with the disease. Maybe these are the issues. And I didn't know. So I thought, well, I'm going to have a look. I'm going to find out the evidence. I'm going to delve into this, and I'm going to research it, have a little look at it. And it's weak in terms of whether there is any benefit from a respirator over a mask. And in fact, it's quite interesting, some of the evidence that's out there. There are papers, they're not great, they're okay though, that actually compare the N95 masks to surgical masks. And there are human studies on this. So it's not just that they've put it on a machine and tested it on the machine, because those ones actually don't really show us what's happening in real life. What you really want is somebody that wears the mask, and we look at the infection rates between the two types. And it just so happened there are various studies that were able to do that ethically. It's not really ethical to turn around to us and say, right, you lot wear a surgical mask and you lot wear a respirator, and we'll see which one of you gets ill first. So these studies were done just because of the availability of the masks and the respirators. And what they actually found, that the respirators were a little bit better, but not a lot. So there was only a tiny bit more sort of protection from wearing a respirator over a surgical mask for these healthcare workers. Granted, they were looking at influenza, and that is obviously a little bit different. I'm not taking away the fact that we're dealing with something that's very different, but it's very similar in terms of how it potentially could infect us in some ways. Don't take me completely on that. And they also had a look at surgical masks against non-surgical masks. So there were people that didn't have a surgical mask, and there were people that did have a surgical mask, and they saw that there was a huge benefit for the people that were wearing a surgical mask. So the evidence is really quite interesting, in my opinion. Anyway, I like this sort of stuff, and I'm going to move on now to talk about aerosols. And yesterday I got angry again, and I've been getting angry, and I do feel sorry for my family and my wife. And probably the other people that I'm talking to in these meetings sometimes when I'm having these discussions, because I get probably a little bit fed up with being spouted at information that doesn't sort of have evidence, and sort of making us look like we're dangerous places to work in, and making us scared of some of these things that we're dealing with. And it does get me quite angry. So this was something that I put up last night, and in that annoyance that I took from the SOP that we were given for the Office of the Chief Dental Officer. So if you are watching, you did put it up, you've taken it down, but it doesn't matter, I got it. And it said, this was what it was worded like: AGPs can produce airborne particles less than 5 micrometers in size, which can remain suspended in the air, travel over a distance, and cause infection if inhaled. And that little bit there, cause infection if inhaled, okay, that wet me up a little bit. Therefore, AGPs create the potential of airborne transmission of infections that may otherwise only be transmittable by the droplet route. And for some reason, that just wound me up. I didn't like the wording of it. I'd already looked at other papers and sort of other comments that had been made. So we got one from Europe, and you know, I remembered what I'd read on that one. So therefore, the event of a widespread community transmission leading to shortages of PPE, a rational approach would necessitate prioritizing FP2 and FP3 respirators for care activities involving a higher perceived risk of transmission. Now, for some reason, that sentence just sits a little nicer with me. It's almost like they actually understand that it's a perceived risk and that it's not a definite risk. And I like that, because it is a perceived risk. And I get why it's a perceived risk. I understand why we might think about that. And it's a logical thought to have. You know, we're dealing with, and I'm going to go into what we're dealing with a little bit more, but we're dealing with aerosols, and we kind of, you know, from everything that we're understanding, that they might actually be a problem. They could be infective. So I get that, but there's not, you know, the evidence is sort of sketchy, if I'm honest. So when we look at aerosols, we've got to kind of understand that we're dealing with aerosols all the time. And people sort of emit aerosols when they're breathing. And that's hence why we've been given these social distancing rules. And I've got to speed up because everybody else is going to be talking, I hope, and sort of emitting on it, contributing to this. So I know that I ramble on sometimes, and I do apologize for that. So Kate, just please tell me to keep going and not to ramble. Keep going. Yeah, okay. And it depends very much on the individual. So the evidence, when we look at this, it's sort of their breathing, their speaking, their coughing, their sneezing. It can depend on the amount that these aerosols travel the distance, the energy behind these aerosols. We've got this sort of tidal volume. So when you're sitting there relaxed, you're breathing out and you're creating an aerosol when you do that. When I'm talking to you now, there's probably little droplets on my laptop, I'm afraid to say. So I'm creating an aerosol as I'm chatting away. My mouth's drying up, so probably not quite as much as normal. But the louder I get, then the more aerosol is going to be produced. And the quieter I get, then maybe a little bit less. People are different in how much they can produce, so they're all individual. So some people produce a little bit of aerosol, and other people can produce quite a lot of aerosol. And I have to thank Domenico Huli a little bit as well, because I've been reading some of the stuff that he's posted on Facebook and some of the webinars that he's done. And I have to say thank you to him, because he's kind of given me the sort of some of the information. He's helped me not have to trial through the papers. I think he's done it himself a little bit. So he did a lot of the research on this himself, and I've got to take my hat off to him and give him a little nod. And we, you know, are these always infective? And are they infective for what we're dealing with in this pandemic, these aerosols? We're being told to socially distance 2 meters. And I did some research on that as well, because I was really interested in the aerosols and where we got that. And I wasn't really looking at where we got the 2 meter rule from, but I was reading a lot about the research about aerosols early on. And I qualified at Birmingham, and some of that research was done at Birmingham by Basu and a couple of other people that I was fortunate enough to have teach me, really quite, you know, back in the sort of the 70s, 60s. And then there was Marsh and Martin as well that also looked into aerosols, especially when it came into the dental field. And some of their research is quite good. And maybe I should clarify a little bit that my background before I was a dentist comes from a microbiological background. So what I did is I studied microbiology for 2 years, and it was that long ago that sometimes I forget that. But part of that was to also sort of design experiments and to understand these things. So I've always had that analytical nature. And so when we're looking at that, we're looking at, you know, whether these aerosols can be infective. So we certainly know that measles is, and that can be a very infective. We know that TB is, and we've been dealing with these aerosols from the time that we qualified, if not, well, before when we were students. And we've got to ask ourselves, is SARS-CoV-2 primary spread in an aerosol? And we need to sort of have a little look at that and have a little think about that. And when I looked for the evidence on this, I found various bits of research, and all the research, it's new. It's new, and I can understand that. It's new and up and coming. But the one thing that came up again and again, there was no viable virus proved in aerosols. So they haven't managed to get any SARS-CoV-2 from aerosols, which is I think quite apt for what we're dealing with. But they can get it from droplets. So droplets, formites, and contacts. So formites when you're touching something, so cardboard, post, door handles, things like that. Contact when we're shaking hands, which obviously we're not allowed to do anymore when you're hugging somebody. And then droplets from the actual droplets themselves, so the big sort of bits, if you like. And then we come on to dental aerosols, and I think the AGP have been very good in the way that they've had a look at aerosols and the way that they've sort of explained it. I did like the way that they did that. I thought that was very apt, and I was impressed with that. So we're hearing this sort of aerosol generated procedure, but a lot of the time they're ignoring the fact that these patients are potentially aerosol producers with the breathing and the coughing and the sneezing, and they're focusing on what I think is possibly the wrong side of things. And so what is an aerosol generated procedure as we kind of understand it from a dental point of view? Well, it's when you're using the ultrasonic. So it's when perio treatment was being provided and you're not using hand scalers, and we can talk about that a little bit if you really want to. So hand pieces, so when the hand piece is accessing the tooth and drilling the dentine, and then the 3-in-1, the triple air when you're blowing the air and the water. And you know, what's the evidence that they're a danger? Where's this evidence come from that they're actually a dangerous sort of thing to be dealing with? And there isn't any. There isn't any evidence that these things are dangerous, and that's probably what winds me up. I can understand it. I can understand why people feel like that, but we need more evidence on this. We need to find out whether they are actually dangerous or not. So I think that's really important. And some of the evidence that I read, there were various papers that had a little look at this. So one of the papers, what they did is they got agar slides and they put them a different distance from the patient. It was actually a live patient, and they performed some ultrasonic work on the patient. And then they measured the amount of bacteria in these agar slides at certain distances away. But one thing they didn't do is they didn't use any high volume suction. So they actually got some growth on these agar plates. The control wasn't very good either. So it's a poor paper. And this is what I come back to. The papers are really either badly designed. I have to be careful not to swear. They're either really badly designed, or they're not randomized controlled trials. It's almost like they're trying to prove a point. And I think when we're scientists, what we've got to do is we've got to make sure that we don't let our bias get in the way of what we're looking at. We have to be unbiased in what we look at and how we look at things. And that's very difficult sometimes to do. And we can have an opinion on something, and sometimes we're swayed into the way that goes. And I've seen some of the comments on Facebook, and I've seen that people are, you know, I try not to take too much notice of it, but I've seen people get into huge arguments and not have any evidence behind their arguments. It's just the way they feel, and that's okay. We're all okay. It's all okay to feel like that. But when it comes to dealing with what we deal with, and this is an important subject, we need the evidence, and you know, hopefully that's going to be sort of forthcoming. So we talked about the aerosols that are coming out of the hand pieces and the ultrasonics, and the one thing that I'm also interested in is from a point of view, I'm just rambling on a little bit now, sorry, is, you know, what happens with different types of products that we put in the water lines. Obviously, they've got to be safe for patients. I was curious as to whether that has any effect on patients. I know that there are various things that go in the water lines, lubrication and all that, and is that going to be an issue? But then we got the complex aerosols. This is the aerosols that then being produced that go into the patient's mouth and then come back out again. And this is the stuff that's scaring a lot of people, I guess. You know, it's mixed with saliva and blood. Is that an issue? Is saliva an issue for what we're dealing with? Is blood an issue for what we're dealing with? Or is it just the patient's breathing? Is that the main issue? I mean, this virus, it sort of sits here in the nose. It's ACE2. get receptors on the virus, and we've got lots of these little ACE2 receptors in our nose, and we've also got them elsewhere in our body as well. But if it's sort of sitting here and the patient's breathing, is that more of a concern for us than the saliva and the blood and the aerosols that have been produced? We've got splatter. So there's a little bit of research on the splatter that's coming out. We've got these droplet nuclei that are formed when we create these aerosols. These little droplets sort of float up and then evaporate a little bit, and they sort of float around. And these are the things that people are a little bit concerned about, and what they sort of relate to with fallow time, and how long are we leaving it for these things to sort of settle down out the air. And one of the things that really helps with this, a huge amount, looking at this research, is high volume aspiration. And there's a little image I've pinched there from a guy called Wally Wren, and he's doing some research into this. There are other papers out there that they're just not quite finished yet. And there are some ones that have been shown where they put an image and you can see in the background the aerosol sort of disappearing up the high volume suction. But this research looks interesting, and I'm sort of interested in the way this goes, and I think more research needs to be done on this. But the high volume aspiration alone really reduces the amount of aerosol that's coming out of that patient's mouth and coming into the atmosphere and hitting us and going around the surgery by a huge amount. I mean, we're looking at a difference between sort of 97 and 98%, which is massive. And what they've done here is they've just looked at different ways of doing it. So aerosol generated exposure, and this is what I like about the way that the AGP, I'm not paid by them, by the way, at all. I've looked at things, and I just really like the way they looked at it. They looked at it in probably a very common sense way, and they're trying to lower the perceived risks as a whole. So when we talk about aerosol generated exposure, I do like that. I prefer that. So what have we looked at, and what are we kind of being given in the SOPs? Well, one is to sort of triage our patients. We're asking them questions prior to coming in. Have you been to Italy? Have you had a temperature? It's interesting measuring their temperature. I was fortunate enough to suffer with, well, I'm going for a test on Tuesday to find out whether I had COVID or not. It certainly felt like it. I had all the symptoms, but one interesting symptom that I didn't get is I didn't get a rise in temperature. And I'm, grateful that I'm still around. It wasn't a pleasant experience, but obviously I'm aware. I've had friends that have got relatives that are no longer here, and my heart goes out to them. It's very difficult, and I was in and I'm not going to go on about how it was for me too much, but there are times when you're coughing and you can't get your breath, and you panic a little bit, and it's worrying. So I don't think I'm doing this and thinking, oh yeah, I'm going to be all right. It's absolutely fine. I don't take this lightly at all. I understand everybody's concerns. We look at the alert level, and that can be local and that can be nationwide. So we're looking at the R number. If that's below 1, then that infective rate's it's dropping, it's going down. We look at the sort of the pre-treatments that we can do, and mouthwashes have been talked about. And again, we can sort of discuss this on the panel and in the audience in a little bit more detail. And it's a shame, because some of the papers that have sort of recently come out have kind of shown that some of these mouthwashes are probably not going to be that effective. And it was sort of quite interesting that chlorhexidine mouth rinse was used, but it's very good at getting rid of the bacterial count, but then not viral. So povidone iodine and hydrogen peroxide were sort of banded around a little bit. But the problem is, and these pesky patients, they have saliva, and it gets washed away. And I think if I remember rightly, the paper that I read said that within 20 or 30 seconds, it's pretty much lost its effectiveness, which is pretty quick. And the patients, they're still breathing. So we've still got the aerosol from the breath. High volume aspiration, we can use that on these procedures where we're using something that's going to create an aerosol to help with that. And I've just discussed that and how effective that can be. Rubber dam, when you can use it. Obviously, if you're doing hygiene, not really that practical, but it is effective. The studies have shown that. Ventilating the room, again, pretty much most rooms do have some type of ventilation. I've put air conditioning in there and not recirculating. So Public Health England sort of did modify their document not too long ago, saying that air conditioning can be used, and you can understand that, circulating the air as long as it's coming sort of externally, however the air conditioning set up. And you can talk to people about this. There are people that are sort of understand about this ventilation that you can have chat to, and air purifiers. So air purifiers have been bandied around, and there isn't a lot of evidence about air purifiers, but it kind of makes sense. And I think that, you know, if your patient walks in and they are a little bit worried about it, and you kind of go, yeah, we've got an air purifier, I can't see a major issue with that if that's something that you feel like investing in. But there's no evidence that SARS-CoV-2 is in aerosols. There just isn't any evidence out there about this. And that doesn't mean that it isn't. I'm just saying that there isn't any evidence. Unless I've missed it, and if I've missed it, please send it to me and I'll be happy. So yeah, I've put universal precautions there because I was really interested in what was sort of happening to us as sort of dental professionals prior to this. And what we didn't see is we didn't see sort of spikes in influenza. We didn't see sort of spikes in measles or TB or any of these airborne viruses within dental workers. It's just not reported, and it's not being reported now either, when we've sort of started to go back to work, and in some countries they didn't stop. And when we look at worldwide, I'm going to just talk about that a little bit. When we look at the worldwide side of things, one of the things that when I was talking to somebody that sort of doesn't make the decisions but helping making the decisions, they said, well, we've got to look at what the rest of the world are doing. And it really annoyed me, because I thought, well, okay, I understand that you might want to reflect on what they're doing, but why can't we be the leaders? Why can't, you know, I'm not talking about experimenting on people, but they've gone back to work, and you know, not all of them, but some of them, and they're all different in the way that they work. And some of one of the things that I read in the OCDO paper again was that they were basing it on what the rest of the world were doing. They're not basing it on what the rest of the world were doing. There are Norway and Sweden and kind of Finland, I think it is. I looked at what they were up to, and they're using type 2 surgical masks for AGPs, or they were when I looked 2 days ago. And other countries aren't. And I can understand that, you know, it's why you might not want to. I get that perceived risk. But what I'm trying to say is that potentially these aerosols aren't as bad as you may think they were, or we may think they were. So I want to get this message across, and I want to get this message across that we're safe. We're a safe place. And I think that we've got to get that across to the public. Now, I'm not saying don't wear respirators, by the way, and don't wear PPE at all. I'm not saying that in the slightest, but I'm saying we've got to question things. And, you know, what we've got to sort of, I think, really do is make sure that they don't stick us with anything that we're going to base it on non-evidence. We've already been stuck with enough non-evidence regulations, and it really irritates me. And I think if you really want my personal view, we've kind of been left like kids, and we're looking up to our parents and saying, please tell us what to do. And our parents are sat upstairs drinking their red wine and their gin and tonic. And when we make a noise, they just tell us to shut up. So we don't know what the boundaries are. We don't know what we want some serious guidelines, and that's what we look for. But I think that what we've got to do is grow up. We've got to grow up, and we've got to make that decision. And we've got to understand that we can make that decision, because we can look at the evidence and we can say, right, this is what we're going to do, and we're going to base it on this. Because we are safe. We're no more risk than going down to Tesco's or Waitrose, where somebody's coughed on the broccoli or picked up the strawberries and picked the nose and then put it back again, or B&Q, or the hospitals, or public transport, or hairdressers. I certainly feel safer going to a dental practice than I do going on public transport. Hairdressers, petrol stations, garden centres, beaches, Just Eat, Post Amazon. So what I did finally is I went for the top 10, because this is kind of where we are. We're looking at top of the stocks. So I'm not putting this in any particular order, but I'm going to say at number 6, we've got Portman coming in, and then at number 5, climbing nicely, FGDP. And then number 4, the European Federation of Periodontology. 3, BDA coming in nicely on the heels. And then yesterday, or this morning, depending on how you look at it, Office from the Chief State Officer. But I think at number 1, you've got to do it yourself. Look at all this and do it yourself. And I'm going to end my presentation there. And I'm going to thank you all for listening to me, and we'll try and bring other people back in again if they would like to join us. Kate, if you chat away, ramble on, and we'll try and get all the guys and girls back in again, if that's okay.
Right. Yeah, that's great. Thank you, Carl. We've got some questions coming through. Obviously, a lot of them are very keen to hear about the PPE aspect. So if we can grab the others back as well, I believe we're going to have Will talking about fit testing. So that will help. We've also got some questions with following on from your talk with the what mask for what procedure. So I think as a panel, we will put that out to everybody. I'll just wait for everybody else to come back in.
Hi,
Carl, just interestingly, Carl, one of the questions we did have, and I'm just picking up on you saying about you not having a temperature, one of the questions we had sent through was about temperatures, and just saying, you know, is there any point really? You know, are the tests reliable? Are temperature checks reliable?
Okay. I will not do what I normally do and give a very succinct no. Again, I think that I don't think there's any problem with measuring the temperatures of patients, whether it's reliable or not. I think I'm a good example of that. But you can't have me as a you know, something that you base your SOPs on one person, because other people do get a temperature. It's reported. It's reported that lots of people get temperatures. How you measure that temperature, what you use, what equipment you're using to measure that temperature. Well, again, how reliable are the thermometers that are being used? So reliability of that, I'm not certain that it's hugely reliable. Is it helpful? Yeah, it probably is. I don't see a reason not to do it. But I wouldn't be hugely disappointed if it wasn't done. So yeah, that doesn't really give you a definitive answer. And I think if you're looking for definitive answers, then this is where we kind of at, and it's frustrating because we can't give huge definitive answers because we're all in this new world and we don't know the answers. But if we can mitigate the potential problems and lessen the risks, then I don't see any problem with taking temperatures.
Thank you. Will, we were hoping you could have a chat about fit testing.
Yeah, of course. I'm a little bit older than Carl, so I'm allowed to be even more cantankerous, especially like everyone else who's been sitting at home, you know, talking to their patients who have been in pain and suffering, and then also in the way that the profession's been treated over the last 3 months, especially in the last week. You know, with the communication that's coming down from above. But again, you know, before I start ranting, I think dentistry has always been, certainly maybe in the last sort of 10, 15 years, a profession where we've been made to jump through hoops. So in some ways, we're actually pretty good at this. You know, we're sort of very much used to it from when things like CQC was introduced and so on and so forth. And once you get a hoop, there's a sort of knock-on effect, isn't there? You sort of, then it leads into another hoop that you have to jump through. So in particular, like Carl's saying, everything is suddenly revolving around PPE, and especially masks, and the differences, like you say, between the level 2, level 3 protection. But of course, that's not the end of the problem, is it? Because what you find is we're all having a bun fight now, aren't we, to get things like this, and then some people are getting good ones, some are getting bad ones, and the next thing you know, well, you have to get them properly tested. And I guess if you are going to be investing that money, taking that time, somebody get that? If you're going to be investing that money and taking that time, and like you say, Carl, we don't know for sure. So let's say we have to assume it's worst case scenario, and this virus is so much more contagious, then, you know, we want to look after ourselves, our staff, and our patients. So if we're told to jump through the hoop, and it means to do that, you know, we get to carry on working, then that's what we're going to do, isn't it? So I've been lucky enough to actually go on a mask fit testing course to really You know, I'm no leading world expert. I think what struck me is now these are testing courses that have probably come from industry first and foremost, for, you know, people working on building sites and with noxious materials, which is now being adapted to the dental profession or the medical profession, because we're the ones who want them now. And so first of all, obviously, in goodwill, we all gave our masks away, didn't we, and all our PPE. And then at a week's notice, we're told that we need to get it all back again. So go out and buy it at inflated prices. So anyway, that's by the by. You've got to get testing done now, really. I think if you want to sort of validate that you are doing the best for yourselves and your staff and your patients. So when you go on one of these testing courses, or if you're just being tested, some of the things that you can expect. So obviously you've probably seen pictures of your colleagues with big hoods on, giving the thumbs up while somebody's squirting something at them. So essentially all it is it's checking that, one, you can put these things on properly, okay, and get a good seal. Once that's on, you're going to be tested for sensitivity, and basically what's being used is a bitter substance, titanium benzoate, or Bitrex, I think is the trade name for it. And essentially what we're doing is you're going to be tested by having a little nebulizer with a bit of stuff being poked through into this little hood that you've got on, and it's going to be squirted at you whilst you are doing a number of exercises. So that will start off with normal breathing, deeper breathing, turning your head side to side, moving your head up and down, talking. There's a little poem that you can get given, or you can count backwards from 100, bending over, and then back to normal breathing. Now this takes about a minute for each one of those, and the nebulizer is being squirted in about every 30 seconds. And if your subject can taste or is aware of that bitterness, then hands up, and it's a fail. So it's an all or nothing thing. You're either going to pass this or you're going to fail it. And if you fail it, then, you know, it's back to the beginning. You're supposed to wait about 30 minutes or more, wash your mouth out, try and get rid of all the taste, and then you have to go again. So the one thing that I'd say to people from experience is try and think about the time factor that's going to come into this if you're testing numbers of staff. There's other practical things as well. Gentlemen, beards are very much in fashion now, so it's probably better, yeah, you have a good shave or get a nice goatee. And so mask fitting for someone like me who's got several chins is not a problem. Okay, the masks will fit nice and snugly around my face, but you may have ordered 1,000, 2,000 pounds worth of these things, and your face compared with your little nurse's face is going to be completely different. And what I found was some of the masks were just too big for some of the smaller subjects. And so that can become a problem in itself. So it's not just about the quality of these things, does it actually fit your member of staff? Because if it doesn't, then what are you going to do? You're going to order another £1,000 worth of smaller masks. How are you going to get over it? So these are little sort of practical things that I think people need to think about. And also in terms of getting hold of testing kits. So I've got a testing kit ordered, but I don't exactly know when I'm going to get it. So it's all very well me having masks and washable gowns and all the other stuff that's annoying my girlfriend by clogging up the house. But until I think you've got that mask fitted and everybody's passed it, you're effectively out of action. So that's my experience. I don't know if anyone's got any questions on that.
Cheers, Will. I have actually, which you may or may not be able to answer.
Probably not, but far away.
Yeah, one of the things that was being chatted about, and I think I've actually seen it in the chat as I've looked up and down a little bit, with the KN95 masks that I was talking to, having ear loops on and not tying them. Have you found that that's an issue or is it something that you can't actually answer just because you haven't had the experience? Anybody?
I think lack of experience. I think the first thing I noticed, because again this was new to all of us, was everybody was fumbling around trying to work out whether they put the bottom strap on first and where that sits, and then the top strap, going above your head. So really, I think most of these masks are looking at the double straps that go over the top of the head and hold it in place, as opposed to ear loopy things.
Yeah. Thank you. Any questions that you have for us at all, Kate?
Yeah, I can go straight on to them. One of the questions that has come through is regarding what is the highest risk as a hygienist, if any of you want to take that up.
Yeah, okay.
Thank you, Carl.
That'd be I'll tell you what, it's real quick for me, and I'm not being flippant. It's your travel to work. That's probably your highest risk. When you look at the stats, the risk of being in an accident on the way to work and back, assuming you don't live in the same building, I guess, is higher than the risk of you getting COVID. What happens with that is slightly different, maybe. And maybe I am being a bit flippant. There are obviously risks, and I think that's a really good question. And Faye, I'm going to pass over to you to answer that.
Thanks. Hi, everyone. I personally feel that the highest risk for a hygienist is not having a nurse, because we know that 90% of aerosols actually go up the wide bore aspirator tip, and that's how can you possibly do that and do your work as well. So if it means hygienists are routinely able to have the assistance of a dental nurse, then that's something really, really positive. I also noticed that someone was asking, do we need to change the wipes? And I think at the moment, no. Just use what you have in the surgery until we get any more evidence. I think things can just carry on, really, not to be afraid. Keep going.
Should, if any of you will pick this up, should respirator masks be used for hand scaling?
No. No.
I think that
a good dental nurse.
it comes down to mitigating the risks, doesn't it? And I think that I agree with Faye that it is an opinion, and it's my opinion, and I agree that no, because what we're being told, and it comes back to what we're being told on a lack of evidence, is that there are aerosols being produced, and the Masks Aerosols are coming from the ultrasonics, the 3-in-1, and the dental handpieces, and that mixture, that complex aerosol that is generated from that, and that's the danger area. But what's being ignored there is the breathing, which I talked about as part of the aspect of what's happening when patients walk in. They're talking to us, they're coughing, they're sneezing, they're still going to breathe when we're doing hand scaling. You can ask them to hold the breath, but hand scaling takes a little bit longer than an ultrasonic, and I think that for me, I've heard that, and I've heard and I've read the comments that it is as ineffective as an ultrasonic, but you need to be having those conversations with your patients, because it is ineffective, and those studies do show that it's comparable, but the difference is time, and time, I'm afraid, we don't work in a place where time isn't money. Time is money, and these practices are, let's not beat around the bush. They're businesses, and they've got to survive. So I think that it comes down to maybe a changing of the conversations that's had with the patient, and hopefully, as we go through the process, and I hope it's in a short time and not too quick, that as the levels come down and we go down to sort of level 2 and level 1, that there'll be a relaxing on the AGPs and what they call the fallow time, which leads nicely into sort of fallow time, and how long we leave it for those nasty little horrible aerosols to exit the room. Does anybody want to talk about that and fallow time, and why in some of the SOPs it's 60 minutes and why in other SOPs it's down to...
Briefly, Carl,
Yeah.
just going back to which type of mask might be suitable for which procedure. I think the problem is sometimes that as a profession we're looking for black and white where there's a lot of grey, and so to start off with, it may well be you as an individual deciding whether you're at risk from the patient breathing on you, or you're at risk from you picking up an ultrasonic or a drill or what have you. So I think if people are looking for answers with that, probably for now, I'd say personally, it's going to be personal choice, isn't it? Like some people like to walk down the road with a full respirator on, and that's personal choice, because it makes them feel better, doesn't it? And it may well be that your staff are going to feel more comfortable, even with a patient having a checkup with a level 3 mask on. So it's probably just going to be personal choice for now, in the absence of evidence. I agree, Carl.
Yeah, I always love your pragmatic guidance, Will. You always kind of bring me back down to earth again. So thank you.
You're close to starting a revolution, Carl. So I'm just trying to temper it just a little.
Yeah. I mean, one of the other things that sorry, Kate, did you have a question?
I do, but you carry on.
Oh no, you asked. I'll ramble on forever.
No, not you. Are reusable FFP3 masks an option? Reusable, sorry. And if so, how is it best to disinfect them after an AGP session?
Should we talk about this? Anybody want to chip in? Yeah, you know what I think.
It's difficult, isn't it?
Fadi, what's your thoughts?
I
don't think there is such a thing as expertise in this. I'm certainly not one if there is, but what we are following is what we are planning is to start with the IMOS, hopefully the manual surgery service again. And the advice we have that, yes, we can use the reusable FFP3. I think the ones we have is the stealth one, which we'll be using. And the idea is to wear a surgical mask on top, and you can change the surgical masks between cases. And I think the filters for those, again, depends on use, what you've been doing, and how much need to be changed up to a month, I believe. But Will might have a better answer for that.
No, I've covered all bases by ordering both, because I think the stealth one said that they could arrive earlier, whilst we're still waiting for some more stocks of these ones. And again, I see on one of the many WhatsApp forums going around was everybody talking how to clean one of the stealth masks. And I think, to be honest, it's going to be like cleaning down any other surface that we have in dentistry. It's going to be as simple as that. Like you say, there's no evidence, so we basically have to throw everything at it. You'll see a lot of certainly in social media posts about people who are really giving it the whole 9 yards in the absence of a set of rules. So they are having the fogging machine, they are leaving it an hour, they are putting the virus machines in place and the high suction and dressing up as though they're in ITU. Just purely probably because people want to start working again and want to start treating our patients.
Yeah.
So I managed to say a lot without giving an answer.
Shelley,
and patients want that perception.
Shelley, as head nurse in a practice, I mean, how do you feel about it? How confident you and your peers feeling? What struggles are you coming across?
I think the closer we get to getting back into surgery and the more sort of guidelines that are released, everyone's feeling a bit more We just want to get back in there now.
Yeah.
It's no good keep sitting at home reading hours and hours worth of guidelines from here, guidelines from there. We just want a simple set of instructions. This is what you have to do. So we're all just looking forward to get back in there next week, hopefully. I mean, there's going to be lots of sort of kinks. And one of the biggest things that's come up is in regards to the PPE, having to go into a separate room to don and doff your PPE. Where is a good place to do that? We don't want to be walking, you know, through the waiting room, past reception. That's one of the things that's sort of sticking in my mind is where is a good place to get rid of your PPE without sort of contaminating the rest of the surgery, as it were.
Over to you guys.
It's not the toilet.
Yeah, for sure.
And the reason for that is because there's evidence that there is SARS-CoV-2 in fecal matter, but whether it's viable or not, I don't know. So no to the toilet. It's not ideally going to be in the same room.
Yeah.
But it might have to be because of the way your practice is set up.
Yeah.
And I think it all comes down to individually setting out your own SOPs and understanding what you can do within your own practice. And that's the key point. And I think that when we all the people that are trying to deliver the SOPs, what we've got to remember is that they've got pretty much the same information that we've all got. Everybody here, everybody that's listening, the whole lot. And they're doing their best with what they've got.
Yeah.
In most cases, they're doing the best in what they've got. And they're trying to offer guidance as best as they can see fit. And that's not always going to fit to the individual practices, but it's a guidance. And you've got to remember it's the word guidance. They're there to guide, and then you adapt that to your own practice and how that works. So when people are saying, well, how much fallow time shall I leave? Well, what's the ventilation route in the room? Is it a room that's downstairs in a basement with no windows and no aircon? Or is it a room that's upstairs with huge windows and doors and miles away from anywhere else? And is it, you know, passive pressure and all this sort of stuff being bandied about? But there is no real evidence to tell you that it has to be. It's not like at 60 minutes, all the aerosols have suddenly decided to settle.
Yeah.
They're not going to go, right, guys,
That's
down,
right.
down, we're on the ground.
Yeah.
It doesn't work like that.
Yeah.
And it's not like, you know, so if we leave some time, then what we're doing is we're lowering that perceived viral load within that room. So I think, again, it comes down to having that conversation with your team and seeing what you're comfortable with and maybe what procedures are being produced. So, I mean, you could get really technical about it, and I don't think you need to, but you could say, well, okay, I've been, you know, using the ultrasonic for 20 minutes, and therefore there's a higher amount of aerosol within the air because I didn't have high volume suction, which you should always be using, looking at what we've just talked about. And therefore I'm going to leave it for a little bit longer. But then how do you manage your patients? So I think you need to sort of sit down and go through individually at the practice level and decide what you're going to use for your fallow time. And I think that probably some people are a little bit scared on what's going to happen if they don't follow certain guidelines that are being told for the fallow time and what the repercussions are of that. And I understand that there's a fear of that. And they're also probably worried about the fact that it's infective air, and they're worried about what's happening. But I hope that I've given some kind of reassurance that it probably isn't. But you know, you can't guarantee that. You can't say for certain. But you know, it's the evidence isn't sort of suggesting that it is. But nevertheless, we should mitigate and lower the risk. So I'm finding that I'm rambling again, and I do apologise. But sort of the fallow time is arbitrary, and I think it's individual to what you perceive in your practice to be best practice within your own practice and what you should do on your own, and sort of have that sort of conversation and as sort of Will and Fadi and Faye pointed out, and have that conversation within the team and see what you're comfortable with, because some of the team might be comfortable wearing a mask and a visor. I didn't mention visors, by the way, but definitely visors. Some of the team might be comfortable in only a respirator. Some of them might want the spider respirators, and some not. You know, you might want all singing, all dancing. They might want a hazmat suit. Whatever takes their fancy. You know, bring out the GIMP. I've got no idea what your team are into, but it could be. You know, you might find Ben turns up in a rubber outfit, Shelley, and
Wouldn't be
No
unusual.
change there then, really. No change there.
No change.
Just another
Well,
day at the office.
That's it. Well, there's a question that come through that you might be able to shed some light on. Someone's heard that some people are refusing to indemnify fit testing by dentists on nurses as it's not dentally related. Will this be an issue?
Yeah, to be honest, this was something that it hadn't even crossed my mind until somebody sent me a text on that late last night. And so all of a sudden it's back to risk-averse dentistry, isn't it? You know, we're bad enough in this profession about being sued or not being indemnified as it is. So I think that's a really, really serious point, because as soon as word gets out that you've done, you know, mask fit testing and you've got your certificate, you become very popular within the profession, and people will give you a call and say, "Oh, can you do us?" And yes, of course, you know, I want to do everything I can to help my colleagues. But now on Monday, I'm going to have to phone up my indemnifiers and find out what is my position, because if I tell somebody, yes, you know, you can fit your mask appropriately and you've passed this test, and they get COVID, who knows from where? It might be from Tesco's, it might be from in the dental surgery. Who's to say somebody isn't gonna point the finger at you? You know, it pains me when we even have these sorts of conversations, you know, but I guess that's the way dentistry has become, and we're constantly looking over our shoulder a little bit, aren't we? You know, and it's I don't know how far these things have gone, but it's something I'm going to have to look into, and I suspect everyone else will as well.
Thank you, Will.
Yeah, I agree. There's a couple of points that I want to sort of chat with, if you don't mind, guys. I'm just going to answer one question where someone's been told that they have to have a COVID-19 test and submit the results prior to returning to work, and then they've mentioned that Lisa, thank you, it won't be as effective as they feel they could contract COVID at any point between the test and their return to practice. Totally agree with that. I think you make a very valid point. It's you know, we don't know how long the immunity lasts with COVID either. You know, we don't know whether it's short or long term. We don't know the answer to that. So I think I can maybe understand why they might ask you, but should you be wearing the correct PPE and following some sort of SOP, then what are they worried about? Are they worried about you infecting the patients? It doesn't work like that, does it? And that's I mean, that is something that the perception that we need to get across is that we are not the infectors, they are the infectees, and they can infect us and each other. And it's not often that we infect patients, if at all. I know that if we go back many years to the States, there was a dentist that infected some patients. And in fact, I looked for the study actually on this. I'm rambling again, I do apologize. But there was a dentist that wasn't autoclaving his instruments. He's no longer practicing. And so what they did is they made that when they found out, they took the patients in and they tested the patients and offered them free vaccines for hepatitis. But when they tested them, there wasn't actually an increase in the hepatitis within the patients, and none of the patients reported any greater infection. I'm not saying you go around and don't sterilize your instruments, but what I'm saying is that it kind of, unfortunately, I don't think it was the correct thing to do, but what it does do is it kind of backs up the sort of theory that we're not dangerous places to be. I don't really advocate not sterilizing your instruments for one moment, but it just so happens you can take from that. And again, it's just some small little thing. It's not a randomized controlled trial by any means, but it just adds to that bank. And I do think you need seriously good studies to have a look at this. And one of the things is some of these studies that are coming out that people are sort of pulling in and saying, well, this and this, they're not peer reviewed. They're not great studies. They're really, really, really weak. And we're basing lots of protocols on this sort of stuff, and the studies are weak. I get that people are scared. I get that they're worried about it. And I've gone off at a tangent, and there was another question that I wanted to talk about. So if you guys don't mind, I'll come back to it a little bit. And it's about putting on your PPE and how you do that and what the correct way to put it on is. And then again, how you take that off, and then what you do when you want to go to the toilet or when you want to eat lunch, and what do we do about that? And I think that is a really quite an interesting question, because we're going to come across these, and our staff are going to cross, and we're going to come across this. And I think that Fadi, if you don't mind, maybe if you could just talk through some of the ways that, I mean, there are videos out there you can download and you can access, but I think being shown how to, and I'm not asking you to show us, by the way, I'm not expecting you to suddenly, Will, you've got your gown, and put your gown on, put a gown on. But if we talk through what we see as a logical process, because there is a logical process, there's a systematic way of putting on PPE, and there's a systematic way of taking off PPE. And the reason that we do it in a systematic way is to reduce the fact that we're going to, certainly when we're doing implant surgery, is to reduce the fact that we're going to contaminate the implant and the surfaces. We want to keep everything as sterile as possible. So we have a way of putting on our PPE, and this is the new way that we're potentially looking at. And that's sort of how we're treating this, really, is that we're going in and we're putting PPE on a certain way, but probably more importantly is what we do when we take it off. What do we do with it? Where do we do it, as Shelley kind of mentioned, and you know, how do we put it back on again, if we put it back on again safely? Sorry, Fadi, over to you.
So yeah, I think, I mean, using the analogy of using the implants, sterile procedures, if you like, it's almost the reverse of that. So the outside of your gowns and the gloves are dirty, so you're almost reversing it. So you're taking your, there is actually on the guidance nice diagrams to show you how you do it step by step, which is quite clear. I like it. And in essence, you mustn't touch your front, your sleeves, your gloves, your visor. It's all contaminated or assumed contaminated. So you take your gloves off without touching the outside, and then you have to clean your hands with alcohol wipe, and then you undo your gown very carefully, starting from the back, without having to touch the front and so on. And you fold it on itself. Diagrams explain it much better than I am. I'm sure Faye is probably cringing with my explanation. That you probably and Shelley for that matter. But in essence, to do that, you also must make sure that your feet, if you you've got to be able to wipe whatever you're wearing, and it's got to be discarded with the clinical waste. Don't forget also the clothes that you're wearing underneath. It's got to be, I don't know if you've been through this already in your presentation, apologies if you have, but in essence, you need to make sure at the end of the day, those are also laundered in the correct way. Most practices don't have a laundry service, neither do they have a dryer. So a lot of people will have to take these home in a safe way and launder them on their own at home. Highest temperature they can do at minimal 40 degrees. So all of this comes into it, but it's all laid out there. If I can take this opportunity, to share a little bit of a positive thing there. Look, I think we will get through this, and as evidence comes through over the weeks and months, some things might change. Our way of doing things might change, and especially as we look at what other countries have done successfully, like Japan, like South Korea, and so on. We can learn a lot from as the evidence comes through. And I just think we need to have a positive outlook, okay? And the other thing that will hopefully come through that could be game changers when we have that, hopefully, antibody tests and antigen tests, which are very quick, over 15, 20 minutes to get results, then those could be game changers as well, make everybody feel better. So this is a period we have to just grin and bear it and just go with what we guidelines, as we say, they are guides, and adapt them with common sense to our situation, protecting the team to what best fits us. And if in doubt, do what you think is the safest way. If in doubt, do the safest way. There's no point in saying whatever you can do within your means. I've said my piece. Does that answer what?
We've all lost our confidence a little bit.
Yeah, very much.
That's all it is, isn't it? Yeah,
Very much.
we need to start somewhere and document everything.
Yeah, I think
everything.
I think there's, from looking at the questions coming through, it's guidance that people are asking for, especially with the
Yes.
fallow time between patients. There's some concern that some people will be cutting corners, so they're wanting more direct guidance, which is echoing through all of this, really. So
it is really tricky because as I think everyone was saying, it depends on the practice. I mean, some practices, they've got surgeries in a basement with no windows, no airflow, and so on. So that's different from somebody who's got massive windows and so on. So I think it does become very much surgery by surgery, and we are thinking potentially, as an example, when it comes to doing consults and non-AGP minor oral surgery, i.e. extractions without drilling and water supply, we will have very minimum time between patients, enough to do the standard cleaning in between cases. When it comes to having a surgical, we are hoping to use, I appreciate not everybody has access to more than one surgery, but if you have that could be one potential way. You do your AGP producing procedure in one room, let it settle for an hour. We can do some consults in the other room. I'm using let it settle in a very scientific way. And then you go to the other room, do your consults or non-AGP producing kind of procedures, and then you can use the other surgery again. That would one way we are hoping to go forward. Otherwise, it is tough. I mean, running any business with having that lower footfall, it's going to be tricky. It means potentially longer days, longer weeks, or maybe having to increase the days you work in as well.
Yeah.
At the moment, there is no easy answer, which is evidence-based. That's the issue. It's just opinions, including the negative pressure. So what is negative pressure? How, there are ways of looking at that, but there are so many variables. As an example, through some colleagues who've looked at this, a 3-surgery practice with a reception room and a maybe 10-meter long corridor would cost them about £5,000 to have a airflow ventilation with filter to set up, and that would potentially reduce the time between patients. But who's going to tell you what can you reduce it to? It's not based on evidence. It's just that's the tricky bit. So we have to do what we think is the safest in our situation.
Okay, thanks, Fadi.
Go on, Kate.
Sorry, what's your views on hygienist polishing? Do you think a surgical mask is adequate?
I've been looking at these questions and wondering, what would I do? What would I do? It's tricky because with polishing before, I would wear a normal surgical mask and a visor. I think during this sort of transition time, I'd perhaps leave it for a while and polish, perhaps, review it 6 months, 9 months or so. It's tricky. I can't answer that in a black and white way, I'm afraid.
Fair enough. Thank you, Faye.
Anybody else? There's a whole load of philosophical questions that are coming out of dentistry now. We've dealt with what is the fallow time, and the other one is what constitutes an aerosol. So is it polishing? Is it anything that produces droplets, perhaps in a surgical? And unfortunately, you're going to get a yes and a no. The more you delve, really. So I think again, it goes back to what that member of staff feels comfortable with. Is it that just breathing alone is going to be producing some form of aerosol that's going to expose you to a virus, or is it going to be a combination of breathing plus whatever droplets or frothy paste that might be flying around? So again, it's going to go back to what members of staff are going to be comfortable with. I think what's useful as well, and what we're going to do, and I'm sure lots of practices are doing, is perhaps try and get a couple of run-throughs of how your day is going to look from, you know, having somebody turning up at the practice, just so everybody's comfortable with it. So, you know, because nobody's going to get it right first time around. You know, everybody's going to want to have their procedure where somebody turns up at the door, they're allowed in, mask on, hands washed, sit down, then what you do in any given procedure. So I think a couple of run-throughs for anybody, any members of staff who are worried or nervous about that, you know, is going to help settle people again.
Thanks, Will.
Thank you.
Can I just ask?
Yeah, go ahead. We're sort of getting close to time, but go ahead, Faye. It's okay.
So someone's asking, would I recommend a high volume aspiration when hand scaling? Yes. Yes. If I ever do any hand scaling, a nurse always aspirates for that, and for using a Cavitron scaler.
Thank you.
We use suction all the time to make it comfortable for the patient.
Yeah, I mean, there's so much more, and we could go on for so much longer. And in fact, actually, if people are interested, there's another webinar on Wednesday. The idea of sort of this was to do a little sort of taster, and it kind of exploded. And I just want to thank everybody that contributed to that. I really sort of don't know. I'm overwhelmed, and I really want to thank everybody on the panel for, you know, it cost me a lot of money to get them on here, I must admit, but you know, I really do.
It's because the pubs are closed.
Yeah.
Friday nights used to be very different.
Yeah. So what I'll do is I'll send everybody, if they're interested, the link to it, but it's with UCLAN. That's up Wednesday with Fadi again. I think you might not be in there. Ian Byrne, myself, St John, and we can kind of chat about this and probably a little bit more. I don't know how long that goes on for, because we could you know, carry on talking about this, and the idea of this really was to try and alleviate a lot of the concerns and sort of answer as best as we can, to the best of our knowledge, the questions that, yeah, and I hope that you've all found it useful. I know that I really do appreciate everyone's interest in sort of tuning in and listening. You know, when I was maybe expecting 10, when I saw the numbers, I was like, oh. So really do appreciate it. So, you know, thank you, Fadi. Thank you, Shelley. Thank you, Faye. Thank you, Will. And thank you, Kate. And thank you, everybody, for listening. You don't know how much it means. And I have to say thank you as well to Kelly. I know she's listening downstairs. And I'm also going to thank my son for not screaming as loudly as he has been during some of the meetings that I've been having. So do appreciate it all. Thank you.
Apologies to those questions that we haven't got round to. We've been inundated with questions prior to the webinar, as well as what we're seeing. So you've probably seen that we've been touching the computer trying to get them. So apologies for the questions that we didn't get round to. There was one I did see about reusable gowns, who to get them from, where to get them from. TRICARE. David, try TRICARE. And well, thank you from all of us. Have a good weekend, everybody.
Yes.
Thanks a lot.
Thank you, everyone. Take care.
Bye.
Bye.